Thanks, everybody, and welcome to another New Ideas in Insurance session. Today, we are very delighted to welcome Tim Layton from Harvard University and also the National Bureau of Economic Research. His two co-authors on this paper were not able to join us, although they expressed their regrets about that. The work he's going to be presenting really opens up a new window in the study of insurance, because while economists especially, but also regulators and others, have been preoccupied with questions of adverse selection for a long, long time, it's mostly been at the level of, well, is there any? And then sometimes, well, how much is there? But what he can do in this paper with the great data and the new techniques that he has is look at not just how much there is, but who's bearing the price and cost of it, and what distributional effects it has. And that's what he's going to be talking about. So Tim, thank you very much for coming. The floor is yours. And if you have questions, you can chat them to me, or you can raise your virtual hand when the time comes. And you've got as long as you want, whatever, 40 minutes or something like that. Sound good?
Sounds great. Thanks.
All right. Thanks again.
Thank you. I'm excited to be able to talk to you all today. This isn't my typical audience, and so I'm glad to be able to share this work with folks who don't think the exact same way I do and hear what you all think of it. So this is, like Peter said, joint work with my co-author Mike Geruso, who's at UT Austin and MBR, who this year is actually at the Council of Economic Advisors in the White House, and so very busy, and he never talks to me anymore. And then Adam Leive, who's at UC Berkeley in the public policy school there. And as Peter said, what we're trying to think about here is essentially the incidence of adverse selection, or the question of whether adverse selection is progressive or regressive, kind of who bears the burden of selection problems in health insurance markets. And what we're motivated by is this observation that many social insurance programs around the world offer some degree of choice to consumers. In this country, we don't have a ton of choice over unemployment insurance options or generosity, but in several European countries, people choose whether they want more or less generous unemployment insurance. In the US, we do have some level of choice for workers' compensation insurance. There's often private disability insurance that you can enroll in that tops up kind of public disability insurance. And the place where we see the most choice tends to be health insurance, that people have a variety of choices. And this choice often takes the following form, where the government or an employer or somebody will provide basic coverage for free or some fixed price. And then there's an option to kind of top up via supplemental coverage at some market-determined price. In other settings, there is no basic coverage for free. And so in that case, there's this other choice between no coverage and purchasing coverage at all at some subsidized market price, like in the marketplaces established by the Affordable Care Act. And many of these programs have this thing in common, which is that they feature strong concerns about adverse selection. And what do we mean by that? What we mean is that the tendency of only the most costly beneficiaries to opt to purchase that supplemental coverage, that more generous coverage. And what does this do? Well, it distorts the price of supplemental coverage upward and leads to too few consumers opting to top up. The idea here being that when the people who enroll or who have the highest demand for insurance are the sickest people or the most costly people, the insurers have to charge higher prices in order to cover their costs, okay? And when they charge those higher prices, the healthy people don't want to enroll. They drop out of the market, the costs get higher, and the kind of equilibrium price that the insurers end up charging tends to be distorted upward above where you would want the kind of efficient price to be. Okay. Now, economists, when we've generally thought about, as Peter alluded to, when we've generally thought about the welfare consequences of selection and what selection really means for social welfare, we've tended to focus entirely on this type of allocative inefficiency, where some people who value insurance more than the cost of providing it don't enroll at the too high equilibrium price. These are people who would generate social surplus by buying insurance because they value insurance more than the cost to society of providing it to them. They don't enroll because the price is too high, and so there's a social surplus loss because of that. But the focus has generally been entirely on these, quote, marginal consumers, these consumers who don't purchase at the distorted price but would purchase at the efficient price. And this social surplus loss is because of that price distortion. The problem is that not enough people enroll in generous coverage. But the thing we want to point out today, which is kind of what Peter was alluding to, is that selection doesn't just resort consumers across plans or across the insured and uninsured states. It doesn't just make it so that there are too few people insured. It also distorts the prices paid by this group that we'll call the inframarginal consumers, who are the consumers who purchase at both the distorted price and the efficient price. They're always going to purchase no matter which price is being charged. And often we think about those consumers as not really mattering for social welfare because they're always enrolling. But in fact, if we think about their kind of private surplus, their private consumer surplus, and how well off they are indeed affected because at the distorted price, they're paying more than they would at the efficient price. And so they have less money, okay, in their pockets. Now, typically, we've deemed these transfers welfare irrelevant because the models we've used have basically treated $1 to one consumer exactly the same as $1 to another consumer. That was largely because there wasn't good data with which to evaluate whether a dollar to this consumer might be better than a dollar to this consumer. Okay, it's also because, this is appropriate if the transfers are small or if the inframarginal consumers have similar marginal utility or other social preferences to the other consumers. Okay. Now, but in the end, it's like pretty unclear whether these conditions actually hold in practice. And so in this paper, we're going to try to answer this question. First, we'll lay out a kind of conceptual framework for determining the distributional consequences of selection that's based on a pretty canonical graphical model of like how we think about surplus in this market. And I'll walk through that, carefully so that we can kind of understand where these ideas are coming from. And it's all in pictures and hopefully is pretty clear. And ultimately, we'll show pretty clearly that the burden of selection is borne by those who have the highest demand for insurance, the highest willingness to pay for insurance. Okay. Then we'll use data from a large public university where employees choose between more and less generous health insurance options to estimate the correlation between healthcare spending risk, willingness to pay, and income. And we'll find a couple of things. First, we'll find really strong adverse selection. Okay, this is a positive correlation between spending risk and demand or willingness to pay. The people who are sicker, who have higher healthcare costs, have higher demand for insurance. That's not new. That's often seen. The thing that we'll see that's a little bit newer is that we'll find that more generous insurance is a normal good. We'll find that there's a positive correlation also between income and willingness to pay. So the people who have the highest willingness to pay for more generous insurance are also richer. Okay. We'll then, estimate a model and essentially simulate the removal of a corrective subsidy that this employer provides to kind of undistort the price of the generous option. And we'll find that if you take away that corrective subsidy, then the highest income group loses around $700 per person in surplus, and the lowest income group loses only around $300 per person in surplus, implying that this corrective subsidy that the employer implements in this market, okay, benefits the high income group more than twice as much as the low income group, and starts to raise some questions as to the utility of this type of subsidy that tends to benefit the wealthier consumers more. Okay. So the key insight that I want you all to take home is that while selection may decrease overall conventional social efficiency, this problem of not enough consumers enrolling in the more generous plan, the burden of selection may disproportionately fall upon the wealthy because of their really high demand for insurance and basically everything else. The idea here is that adverse selection may lead to a kind of separating equilibrium where the sick or high utilizers of all income types choose the expensive or generous coverage, while the low income healthy or these low utilizers choose the cheap basic coverage. Okay? And so if we subsidize the adversely selected option, that expensive generous option, that can get the low income healthy consumers into the generous plan, which may be efficient, but to do so, we have to transfer a considerable amount of money to the wealthy healthy who choose that generous plan with or without the subsidy. So importantly, while it may be socially efficient for the low-income healthy consumers to be in the generous coverage because they value insurance more than the cost, in a kind of conventional model,
they would generally be assumed to get little private benefit from being induced to switch by a small subsidy into that more generous option, because by definition, their willingness to pay for that generous option must be relatively close to the price. And so additionally, when selection corrections are done via a tax on basic coverage rather than this kind of subsidy for the more generous coverage, or via risk adjustment transfers where they take money from the generous option or from the basic option and give it to the generous option, things tend to be even worse, where in those types of settings, the low-income healthy sometimes actually end up giving or paying money to the high-income groups. Okay, so I'm going to try to proceed in kind of 3 steps here. The first step, I'll walk through a graphical conceptual framework for determining the distributional consequences of selection to kind of ask, how do we know when selection will be progressive versus regressive? In the second piece, I'll provide some descriptive evidence from a large employer of that joint distribution of spending risk, willingness to pay for insurance, and income. And there we're going to ask, using the tools we built in the first step, is selection progressive or regressive? And in the third step, we'll estimate like a big fancy demand model and then do some counterfactual simulations where we'll remove corrective subsidies that this employer provides to try to answer the question of just how progressive or regressive is it in terms of like what are the distributional implications of those corrective subsidies. Okay, so the model that we use is built on the chassis of the standard Ina, Finkelstein, and Cullen model, where consumers are choosing between insurance and no insurance. Okay, and when we go to the employer, we'll choose between high and low generosity of coverage, but everything carries over. It's just easier and simpler to talk through the insurance versus no insurance question. And here, I'm going to denote their willingness to pay for insurance, the amount of money that they're willing to pay for insurance by this WTP. And I'm going to essentially take all the consumers all of the employers, all the employees of this employer, and order them along a line according to how much they're willing to pay for insurance. And I'm going to give them different types based on that ordering, where the 0 types are going to be those that have the highest willingness to pay for insurance, and the 1 types are going to be those with the lowest willingness to pay for insurance, and everybody else will be lined up in between. Okay, I'm going to define this SM consumer type as the marginal type that is indifferent between insurance and uninsurance at the given price P. So at any price, there's a consumer who's indifferent between purchasing or not, okay? And we're going to call that consumer SM for the marginal consumer, okay? And now we can go to the picture where I'm going to try to lay all of this out. And the first thing I'm going to do is talk about how we generally use this type of setting to think about how adverse selection influences social welfare and social surplus. And then we'll move over to the distributional consequences and the private surplus. So when we think about social surplus, we need a few things. First, we need for a given consumer to know how much social surplus they generate by purchasing insurance. And the way that we think about that is for a given consumer, say this one right here, okay, when they purchase insurance, okay, this consumer, they get a value of insurance equal to the amount that they're willing to pay to purchase insurance. And that's what this blue line shows us here. So for any given S consumer, I can go up and find the amount that they are willing to pay for insurance, and that's how much they value insurance, how much value they get from insurance. For that same consumer, okay, also find how much it costs society to insure them, okay? How much it costs to insure this person. And that would be the solid red line right here. And so for any given consumer, we'll call the social surplus the difference between how much they're willing to pay for insurance or the value they get from insurance and how much it costs society to provide insurance to them. That's the social surplus generated by that consumer purchasing insurance, okay? The second thing that we need is to know what is the price that would be charged in a market where there's adverse selection, okay, in equilibrium, and what is the price that we would want to be charged that would maximize social surplus? Okay, we can start with the latter first. Okay, the price that would maximize social surplus is going to be this P star price here, and it's going to be where willingness to pay or demand crosses this cost curve. And that's because if the firm charges that price, then everybody to the left of this SM star enrolls, okay? And everybody to the right does not enroll. And why is that the efficient price? Well, this is the price at which everybody that generates positive social surplus by enrolling enrolls, and everybody who generates negative social surplus, meaning it costs society more to provide insurance to them than they value insurance, does not enroll. Okay, so that's the efficient price. And then we need to ask, okay, but what price will be charged in this market? And to understand that, we need to understand how the firms price. And the main thing that's going to constrain firm pricing is that they need to set a price that covers their costs. Okay, they need to set a price greater than or equal to the average cost of the people that enroll at that price. So this is a very kind of circular equilibrium concept where if I raise my price, okay, different people enroll, that changes the cost and so on. And so what I need to do is set the price at the point such that the people who enroll at that price have an average cost equal to that price. And it turns out that that would be where the average cost curve crosses this demand curve. And that average cost curve is being represented by this dotted red line right here. And you can see that this equilibrium price is above the efficient price. And that's because these sick people that are the first people to enroll over here have the highest costs. And so the firm, if it doesn't enroll everybody, has to set the price higher than this kind of marginal cost down here, because it's not just covering the cost of this person, this marginal person, it has to also cover the cost of everybody above them, right? Everybody with costs higher than them. And so that's what distorts this equilibrium price up above the efficient price, okay? And so then how do we think about the welfare costs of adverse selection? Well, it's the difference in social welfare at this equilibrium price versus this efficient price. And how do we think about that? Well, I know that at this equilibrium price, all of these people enroll here, okay? At the efficient price, these people would also enroll. And so I can think about the difference in social welfare or the welfare loss as the social surplus that would be generated by these people who should enroll but don't at the equilibrium price. And so that's that red triangle right here represents the social surplus loss due to adverse selection, okay? Now, in this paper, we're not really that interested in the social surplus loss. We're interested in the distributional consequences or the private surplus or consumer surplus losses. And so we need to look at things a little bit differently. When we think about private or consumer surplus for a given consumer, that's going to be equal to the value that they get from insurance as given by this blue line up here, okay? Minus the price they have to pay for insurance. Okay, so it's taking how much value they get from insurance and subtracting out how much they have to pay to get that product. The difference between those two values will give me the value that I get, the net value that I get from purchasing insurance after I pay that premium. Okay, and so that's going to be the gap between this blue line here, okay, and the price. So in the case where the equilibrium price is being charged, okay, the private surplus is the difference between this blue line and this price down here, okay? And when the efficient price is being charged, it's the difference between this blue line and that efficient price, okay? And so you can see that the private surplus loss by charging this equilibrium price instead of the efficient price can kind of be divided into two pieces. One is the surplus loss for the inframarginal consumers that purchase insurance at both prices. That would be everybody over here. They're always purchasing, okay? And for them, the surplus loss is just the difference in the prices. They're always purchasing, except in this world, they have to pay P equilibrium. In the other world, they pay P star, okay? They're getting the same insurance product, but they get it for cheaper in this P star world, okay? And so they have that much more money in their pockets, and that's how much better off they are, okay? Now, for these marginal types, the folks who enroll at P star but don't enroll at P equilibrium, okay? For these folks, the foregone private surplus is still just equal to the difference between their demand for insurance and the new price. And this is because in the world where P equilibrium is charged, they get zero because they're not purchasing anything. In the world where P star is charged, they now get their valuation, their net valuation, kind of net of paying that price, which is the gap between the blue line and that price right there, okay? And so ultimately, the key insight from this set of figures is that how much you are hurt by selection depends on the probability that you're in this inframarginal group or this marginal group, okay? This inframarginal group loses more than this marginal group, who loses even more from these folks over here, okay, who are unaffected, right? Because they never purchase, okay? But the highest willingness to pay types, the people with highest demand for insurance, they're the most likely to be inframarginal and thus the most hurt by selection. And so if willingness to pay increases in income, if the highest income people have the highest demand for insurance, then the high income groups are likely hurt more than the low income groups, okay? So the incidence of selection is weakly monotonically increasing in willingness to pay for insurance. So if selection is adverse, meaning that the sick have highest demand for insurance, then the high willingness to pay types are hurt the most by selection. If selection is advantageous, we show in the paper that the high willingness to pay types are benefited the most by selection. So additionally, we found that the loss surplus for the inframarginals, the people who enroll at the distorted price and the equilibrium price, is equal to the size of the price distortion. That's intuitive. They're getting the same insurance, but at a different price now, so they just pocket the price difference, okay? The loss surplus for the marginals is actually bounded by the size of that price distortion. It can't be bigger than that price distortion. It has to be less than or equal to the size of that price distortion, because you could see that that if it was bigger than that, then they would be inframarginals, okay? There's a caveat here that if there's kind of people are making mistakes and under or overvaluing things, if there are these types of behavioral frictions, this would cause a wedge between the demand curve and valuation, and the marginals can lose more in that case. We're kind of not going to deal with that much today. We do some in the paper, some exercises around that. But in the end, to assess whether selection is progressive versus regressive, we need to characterize the joint distribution of demand for insurance, risk, and income. We need to understand how the size of that inframarginal group varies by income. If it's the case that the high income groups have higher demand for insurance, meaning there are more inframarginals, and selection is adverse, then selection will be progressive. So these are the empirical kind of facts that we need to go out and find, okay? And so that's what we're going to do next. We're going to try to find some descriptive evidence from a large employer on this joint distribution of spending, risk, willingness to pay, and income, okay? And so we have this data on income, healthcare spending, and plan choices for around 30,000 employees and their dependents from a large self-insured employer. It's a university. And it's a university nicely that has a hospital system attached to it. So we end up with pretty wide variation in income. So we kind of span the income distribution. And for this employer, we observe annual healthcare spending and income in 11 bins. So, somewhat broad information about income, but enough to be able to do what we want to do. But like I said, there's wide variation in employee earnings because there are faculty and staff, there's medical and non-medical employees. So you have pretty wide variation, which helps us to really paint like a nice picture of how willingness to pay and risk move with your income levels, okay? So this just provides kind of a picture of that fact that we do have people from across the income distribution. So we have plenty of employees that earn less than $35,000 a year and plenty of employees that earn more than $120,000 a year. So we kind of have a good range here. Now, these employees have a choice of two vertically differentiated health plans. Both of these plans are very generous. They don't differ in their networks or anything like that. It's just a financial choice. And the high coverage plan has an actuarial value of about 88%, and the low coverage plan has an actuarial value of about 84%. So they're both pretty generous, but obviously the high coverage plan is more generous than the low coverage plan. So what we're going to do is provide some descriptive statistics to show the correlation between income and demand for H, and then we'll provide a richer set of descriptives to characterize that joint distribution. Okay, so this is the first step here, where all we're going to do is show the H's market share, the high generosity plan's market share by income. Okay, what portion of people in each income bin enroll in that high generosity plan? And the first thing that jumps out is that the higher income groups are much more likely to enroll in that high coverage plan than the lower income group. So it does appear that demand for that higher generosity coverage is increasing in income, which actually, according to is the reverse of what you would think according to economic theory, which would suggest that higher income people would be more likely to self-insure to the extent that they can. And so this is a little bit reverse of that, but it's also consistent with other work in other settings showing that higher income people do tend to purchase more generous insurance. And it has, we don't really know why, but we think it probably has something to do with higher income people just generally buying the best of everything. And health insurance is no different.
Do you have a story about, just go back one sec.
Yeah.
Do you have a story about that middle 55 to 65? That's just like a data anomaly or glitch or something? Is there anything, like there's no notches or like is there anything to say about that?
I have not thought aloud about it, except that it's probably just noise. But like, it could be that there's something going on there, but I've mostly thought about it as noise. I think generally you will see that like a lot of this does come from a difference between the highest income group and some of the others. So the right-hand side here, I'm showing new enrollees only to try to show you that this is something that persists even when you kind of take away the inertia that it may be the case that like you see really high enrollment among the highest income group here because like, 20 years ago, only the high plan was offered, or it was like a really good deal. And then over time, they've stayed there and also raised their incomes. We do still see the take up looking like this over here. All right, I'm seeing some stuff popping up in the chat, but I'm having a hard time reading it. But I'm going to keep going unless somebody tells me to stop. Okay, so the next thing we do is kind of cut by both health and income, okay? And what we have is an indicator for whether this person has chronic conditions. And you can see that the people with chronic conditions are much more likely to enroll in that high generosity plan, okay, showing that there is adverse selection here going on, okay? You can also see when we split just by like income greater than or equal to 60,000 a year, that kind of the higher income group still has higher demand for the high generosity plan versus the lower income group. But the interesting thing comes when we split by both and are able to show that among the sick people that there isn't really an income effect. That among the sick people, you see relatively similar take up of the high plan, okay, among the lower and higher income groups. But it's really coming from the healthier people, okay, where it turns out that the high income healthy group is much more likely to enroll in the high generosity plan than the low income healthy group. Okay. We can also look at the full joint distribution in this kind of heat map here, where on the x-axis we have your expected spending decile, which is related to your spending risk or your health status. On the y-axis we have your salary bin, and then what we have in the heat map is the percent choosing H, that high generosity plan. You can see there's definitely a gradient in that expected spending decile, with the higher expected spending decile people more likely to enroll in the higher generosity plan, showing that adverse selection again, okay? But you also see that for any given spending decile, it is the case that the higher income groups have higher rates of enrollment in H. So there is kind of a bit of a diagonal here, but you see that the bulk of the strength is coming from the adverse selection. You can also look at this via a regression, where we put on the left-hand side of the regression the probability that you choose the high generosity plan, and then what we're reporting here are coefficients on a bunch of dummy variables for which income group you're in. That the way to interpret those is the difference in take up of the high generosity plan between that income group and the less than $35,000 a year income group. So this coefficient here means that the highest income group is 20 percentage points more likely to enroll in that H plan than the lowest income group. And then what we do is start controlling for a lot of things and seeing if that gap persists, right? And so we could control for the expected difference in out-of-pocket costs for you in those two plans. It doesn't move that much. We can control for the standard deviation of that to try to get at differences in risk across the plans. Still doesn't move that much. When we include age bins and control for age, it drops considerably. It's still both statistically and substantively important, okay? But it does drop considerably, suggesting that a lot of this correlation is coming from coming through age, okay? Other things we control for, we continue to see this. We can also look at how things changed over time. So one thing that this employer has done over the sample period that we have is kind of jack up the premium of the high plan relative to the low plan because they want people to move out of it to the point that it's almost dominated today. And what you see is as they jack up that price, the market share of that high plan does decline pretty quickly. And the interesting thing, though, is that we see the average income in H climbing rapidly, right? And we also see the average cost in H climbing rapidly. And why is that? Well, that's because the people who are left in H as people kind of flee, are the highest income and sickest groups, okay? So that suggests for us, again, that the higher income groups have higher demand for that high generosity plan than the lower income groups. We also see something similar with age, but much smaller. Finally, we can actually look at kind of how each of these income market shares of H for each of these income groups changes differentially over time by income. So the lowest income group is this line down here. The highest income group is this line up here. And you see that these are kind of like demand curves, and they're kind of parallel in nature, but not quite parallel in that like they're all declining, but that the lowest income group market share declines faster than the highest income group market share, suggesting that the lowest income group is actually more responsive to those price increases than the highest income group, which tells us that their demand curves are probably more steeply sloped. Okay, so in the end, what these descriptives are showing us is there's a clear correlation between income and demand for H. These higher income groups exhibit much higher demand for generous coverage. This result holds conditional on a bunch of stuff, but it does get somewhat weaker within age groups, suggesting that the transfers are partially from low-income young people to high-income old people. Okay? So the results indicate that demand for H among the higher demand for H among the highest income groups. So the high income groups are more likely to be these inframarginals and hurt by selection. So it does look like adverse selection is progressive. What does this mean? It means selection hurts the rich more than the poor. But we need to know how general is this result. We did like scour the literature to find all the papers we could that presented information on income by insurance choices. And we generally found that it was pretty common that higher income groups exhibited higher demand for insurance. Okay, this is true across health insurance, long-term care insurance, flood insurance, etc. There's this really nice paper that I think is part of this series, actually, where they show that this holds for life and property insurance as well. So this is becoming a more robust result by the day. And so adverse selection generally does seem progressive, but now we want to understand how progressive is it? Does it really matter? Is it just kind of marginally progressive? And so how do we do that? Well, we're going to need some way to simulate kind of removing the corrective subsidies that are in place to correct this price distortion, and then see, okay, how are different groups affected in terms of their total utility or total surplus? And so that's what we're going to try to do. And kind of we need two things to do that. One, we need the size of that H inframarginal group for each income group, because if you remember, for the inframarginals, the surplus difference is just the difference in the prices between the equilibrium price and the efficient price, okay? And so if we know the size of that group, then we're pretty far along the way to understanding how that group is affected by selection. And then we also need the size and willingness to pay for the marginal group, the group of people who are on the margin who would enroll at the efficient price, but not at the distorted price. And so to get these objects, we're going to estimate a demand model for H versus L. And it's a pretty standard kind of conditional logit model that we're going to go and estimate. And I'm just going to show you kind of one, that model is doing a pretty good job at predicting the actual market shares given the actual prices in this market. So we think like it's actually representing reality pretty well, and how these market shares of these different groups respond to changes in prices. So we think it's going to be pretty good at telling us what would happen if we simulate other price changes. Two, I'll show you that the model can actually produce these demand curves that I plotted initially. And so what these demand curves are showing us is exactly like those initial plots that I showed you. It's showing us for a given price, what portion of people with a given income are going to enroll in the high generosity plan. And a couple of things to note here. One, that they largely differ in level and less so in slopes. So there are some differences in slopes, okay? But the higher income groups always have higher demand. than the lower income groups. This is the highest income group, right? This lowest income group. The highest income group always has higher demand. It is the case that the model suggests some negative willingness to pay for the high generosity plan for a few people in each of these groups. There's some technical reasons for that, but largely we think that's okay because we're not going to do any simulations over in this range, over here. The model also allows us to plot this kind of average cost curve that I showed you in those earlier kind of graphical model, and we see that this average cost curve is clearly downward sloping, okay, which shows us that there's adverse selection, meaning that, look, with the average cost when only these people enroll would be quite high, and then as more and more people enroll, the average cost becomes lower and lower and lower because the people who enroll, as we move up the kind of quantity distribution here, tend to be healthier and healthier and healthier, okay? And so we're going to use these demand curves and these average cost curves to perform some counterfactual simulations. And in particular, the simulation that we're going to do is, well, this employer, it doesn't charge equilibrium prices. Instead, it applies a kind of corrective subsidy because they know, and this is typical among employers, that that adverse selection distorts the price upward. And so they apply a corrective subsidy and charge a kind of a price that's much lower than would actually be charged in like a competitive market by a profit maximizing insurer. And so what we're going to ask is, okay, what if we removed that corrective subsidy and just let the market determine the price? How would different groups be better or worse off, okay? And the first thing we're going to show is how the market shares for each income group, for H, differ with the corrective subsidy and without it, okay? And you can see that for all the groups, when we remove that corrective subsidy, that fewer people enroll in H. Not surprising, we charge more for H, fewer people enroll in it, okay? And we can actually see that because those demand curves were parallel, the decline in enrollment in H is actually not that different across the different groups, okay? So the size of those marginal groups is pretty similar by income, okay? But the levels of demand for H, the levels of enrollment in H are much higher for the highest income groups, which is going to suggest that they have a larger inframarginal group and they will have more foregone surplus due to adverse selection. And that's in fact what we find when we just go use the model to calculate the foregone consumer surplus for each group from removing the subsidy for H. We find that the highest income group loses much more consumer surplus than the lowest income group. So the highest income group loses about $710 per year per person per year in lost surplus per person with no subsidy relative to the $437 corrective subsidy that the employer applies. And the lowest income group only loses $330 per person per year. Okay. So we could also assess foregone surplus of no subsidy relative to the optimal subsidy. The last one I just showed you, the observed corrective subsidy. We can also calculate the optimal subsidy and do that comparison. Ends up being like a similar thing where the highest income group loses the most, which is not that surprising. Okay, whole bunch of caveats here, just because I always have to do that. The first one being that like the simulations do have to go pretty far out of sample, looking at prices that we don't actually observe in the data. And so we are like extrapolating kind of what would happen to market shares with these different prices. We have done some in-sample only simulations that show similar results. The main caveat is that all the simulations assume that demand is equal to valuation for determining the foregone surplus of these marginal types. We don't think that's a big concern here, and I can go into that some more in the Q&A if you want. But we think that like also all of these conclusions about progressivity or regressivity are somewhat kind of partial equilibrium in nature, because if we really want to think about the overall progressivity of these kind of corrective subsidies, that clearly depends on where the money for those subsidies are coming from. And if the money is more likely to be coming from the rich than the poor, then that can flip things some. And finally, all of these simulations assume the price of the low plan is fixed. But, you know, in a lot of settings, it is often at least somewhat market-based in practice, and so that's not quite accurate. Okay. Finally, you might also be interested in the distributional consequences not solely by income, but also by income by health, as marginal utility is likely the highest for the low-income sick who largely enroll in H, and so maybe things aren't as bad as they look. Okay, so I'm going to conclude with a few key points. First, many social insurance programs involve some degree of choice. Choice goes hand in hand with these concerns about adverse selection and subsidies or taxes to correct selection-induced price distortions. The prior literature in economics on adverse selection has largely focused on this allocative efficiency problem, like, are the people who should be insured insured? And researchers have typically ignored the transfers caused by adverse selection and the subsidies and taxes in these programs, despite these transfers often being the first order effects of the subsidies and taxes. Basically, you've got $1 for $1 subsidy, $1 goes to all the inframarginals, and there are very few consumers on the margin. So like kind of the first order effect is these subsidy or these transfers, and we didn't really know a lot about them before. But we do show that the transfers caused by selection seem to be fairly progressive, meaning that subsidies that correct selection tend to be quite regressive, showing that like if we remove those subsidies, the benefits, the costs are 2 times as large for the high income group versus the lowest income group. Okay, but in the end, we kind of think, if including distributional goals in the social welfare function, then we probably end up with smaller welfare losses due to adverse selection and a smaller optimal subsidy than we would have if we didn't consider these kind of distributional consequences. Okay, so I'll stop there and take questions if you all have them. I'm going to stop sharing too, if that's okay, so I can see all of you.
Great, thank you very much, Tim. So I will take a cue, but let me start off by asking you, you didn't really talk about the possibility that you could have the best of both worlds, maybe by having income contingent subsidies. So why couldn't you, instead of just saying this plan is going to get a flat $437 or whatever, you could say, well, we know how much you make, and we're going to subsidize you more if you're poor to buy this plan, and less if you're rich or not at all.
Yeah, it's a great point. And in fact, like a lot of employers do this. I mean, my employer does this, that like to pay more than to enroll in like the high plan than like the lowest income like Harvard employees. So this is something that happens in practice. We've done a little bit of work on this. I think that like part of the issue with that is like it seems like the natural solution, but in practice, it's actually not clear that you want to give higher subsidies to the low income groups. And that's because they have like lower valuation for insurance. And so they may often be in the group that like, because of that lower valuation, isn't like optimal to get into that high generosity plan, right? And so it's not always clear that like you want to do it that way, but that's definitely something that we've been trying to work out. It's just a little more complicated than it seemed at first blush.
Just a quick follow-up. I mean, so the problem is basically that, the pictorial Einov and Finkelstein and Cullen models shows it's basically you're not just a demander, you're also a cost. So on the one hand, we like you to be there because you lower costs, but on the other hand, we don't like you to be there because you are a rich person, something like that.
Something like that. I think that the thing that's like a little tricky is like how much, from a pure like efficiency perspective, taking away like the equity lens, like how much you want to subsidize that group depends on kind of how elastic their demand is, right?
Okay.
And how much adverse selection there is in that group. And it's not always the case that like between the high income and the low income group, those things move in ways that make it so that the efficient subsidy would be bigger for the poor than the rich. And so that kind of works against the equity piece and just makes it more complicated than it seems. And that's why we've been trying to work it out and haven't quite gotten there yet.
Great. All right, Josh, you're next, and then Tom Baker.
Thanks, and thanks, Tim. This is great. So what I'm about to ask is such a standard question in conversations about this, but I'm just curious what you think, right? So wouldn't we be if allowing adverse selection is a progressive move, right? Wouldn't we be better off solving the adverse selection, getting the efficiency benefit, and just being progressive through the tax code and other ways? Why are we doing it through this mechanism? I know this is a standard question, so you must have thought about an answer.
Oh, it's the most common question I get about this paper, at least in front of the public finance crowd. I mean, this is like a classic Joe Stiglitz result, right? That like we should
always just like do the efficient thing and then correct it via the tax code. I think, you know, our response to that, we have a couple of responses to that. So one is that you kind of need to do what we did here in order to know how much you need to correct on the tax side, right? And so we think like one of the contributions here is just showing the disparities so that you have a sense of like how much you need to correct, which previously was kind of unrecognized, I think. I mean, the other thing to note is that like, I mean, that would be great if we had like an ability to set up an optimal tax and transfer system, which, you know, we kind of take it as given, right? And then say, all right, given that let's suppose the tax system is not going to respond to this, what would we want to do, right? And I don't know, that's not crazy to do because I don't think it's likely that like the tax and transfer system is going to take this into account anytime soon. The place where it could be taken into account is that an employer could easily internalize this, right? Like an employer could do it by actually just inducing these kind of like reverse transfers via their pay, right? And I don't think any are doing that because like we're pointing this out here, you know, I think for close to the first time, but I think that's one of the messages that we want to send is like, if you are going to do this, which, you know, I think personally, I think that's what you're saying is exactly right. What an employer should do is set the efficient subsidy, right? Like the exact optimal subsidy, and then kind of pare it all back via their wages and things like that. And so we just want to kind of make that clear as to how much they need to do that. But it's a great question, and yeah, one that I've definitely heard before. Go ahead.
Okay, Tom Baker is next.
All right, so I'm going to put on my like vice president of finance hat at Penn, and
Is that what you're wearing right now?
yeah, and I did a project with where we studied what happened when Penn adopted a high deductible health plan. And so these are things that I've thought about, and you know, things are so unequal by salary and status at universities that I guess my reaction to this is like, you know, like the faculty are benefited in so many different ways that the real question is are the right people getting the right kind of insurance? And that I'm just not worried about the subsidy. And so what about your results suggest that the right people are not getting the right kind of insurance? And then how do we fix that? You know what I mean? Like, because that seems tractable. Whereas like coming up with like the optimal price and I really commend you to read Travis's paper that he presented at the last time when it's done, because he really talks a new way that I've never seen anyone talk about before about how we should think about dividing up the social surplus. Because that's really kind of what you're talking about. It's like, how do we divide the social surplus in a context in which we're actually prohibiting risk-based pricing? And anyway, so the question is like, are the right people getting the right kind of insurance given the information that you have? And if not, what should we be doing to have that happen?
Yeah, I mean, it's a good question. There's a lot there because, I mean, according to like our model, it's not that bad that like the price that the firm is setting is getting pretty close to like getting, and to be clear, like in our model, the firm just has one instrument, which is that single price they can set.
Right.
They are setting it at a place where the bulk of people who generate positive social surplus by being in the high plan are in the high plan, okay? But our model is incomplete in a number of different ways. I mean, we're not modeling anything about like any kind of mistakes or anything that people might make. So my co-author Adam has like other work where he tries to do some of that, and those could make it so we're not getting it to the right people and things like that. And we're not really dealing with that. I think like more broadly, I think what we want to just point out is, this is related to the last question too, right? That like, I still think that we want to charge probably the optimal price, right? And like get people to do exactly what you're saying, get people into the right plans. And then and to the extent that that requires us to like transfer a bunch of money to the richest employees, let's carve that back via like the wage, right? Like let's set the right price and like
even if it costs us a bunch of money sending money to the rich employees, and let's just carve it back via the wage. But I think previously, like, it was just kind of unknown how much, when we set that subsidy, how much extra of that subsidy is going to the rich employees versus the poor employees. And so I think part of our goal is to show that gap so that employers have a better idea of how much kind of carving back they should be doing if they're worried about, you know, maintaining that type. If, you know, I think that when employers kind of set these subsidies, that they're not thinking about like these equity consequences at all. They're just thinking we want to get like the right set of people into the right plans. We want people to sort efficiently. And we're just making this point that there is this kind of equity trade-off. And if you care about that, you know, you probably want to carve it back elsewhere. And that's about it.
Okay, I don't see any other hands up. I've got a million questions. Laura Arp, you had some good observations that you shared before. Do you want to come in? I don't want to cold call you, but do you want to ask?
Well, I love this. It's really interesting to compare what you've pulled out of the employer group compared to the ACA individual market and what happened there. And one thing that we really saw just watching enrollment happen is when the threshold for the subsidy cliff got moved higher. So it used to be 400% of federal poverty level, and then in 2021 it went up. But there are still people who are completely unsubsidized. And if you look at like 2016 to 2019, about 50% of the people who are unsubsidized, at least in the states with high rate increases, dropped out. So we watched that adverse selection play out in our individual market. And what I'm wondering is there some way that employers could be sensitive to watching how people drop out and gear their program toward that? Is there like a magic formula to try and be more sensitive with that?
Yeah, that's a good question. I think, you know, the extent to which people drop out tells you something about their like demand elasticity. It tells you if you are willing to like extrapolate from that to how much people value insurance, that you could get you could get a picture of like, and be able to simulate, you know, if I like set the price higher and higher, how many people am I going to lose? If I set it lower and lower, how many people am I going to gain? And try to set it at a point where you get like the level of enrollment that you want, and try to get a sense of like, you know, we want a lot of people to be insured, but how much is it going to cost us, right? Like, and like, at what point does it end up costing us more than we're willing to pay, you know, the benefits that I'm going to get? And so I think like the dropout is very informative and like tells us something about what that elasticity looks like, and helps, you know, an employer or just a regulator to be able to know kind of what a lot about the market, like, you know, how will things move as I move that price around. I think that the harder thing in the exchanges to really understand has been the selection piece, largely because it's been hard to get data specifically to that group of unsubsidized people. So like in general, it seemed like the kind of, as this dropout has occurred, like the costs in the marketplaces haven't changed that much. And I think that's just because the bulk of the enrollment are completely kind of sheltered from those cost increases because of the price-linked subsidies. And they kind of protect the market. But what we've had a harder time knowing is like what the selection looks like for the folks who are not protected. And that's like a really, I'm glad you're talking about that part of the market, because it's a part of the market that I think the regulators like pay very little attention to, despite, you know, it being quite important. And like, I think those people have kind of been overlooked, and like, I think it would benefit the regulator a lot more to really like pay attention to that group and understand kind of how they've been affected by a lot of these policies and regulations that have been implemented that generally like raise prices overall, but don't raise prices for the subsidized groups because those subsidies move with the prices, but really hurt the folks that are unsubsidized. But I think that's been a bit of a black box. We don't really have a lot of an idea of what's going on there, but that's an area that a lot of people should start looking into in the future.
Yeah. We call them woodwork people because they kind of came out of the woodwork when the subsidies got changed.
Yeah.
And then we also had some states kind of started doing these association health plans for a minute, or they had, like in Nebraska, we have a couple of groups that had, they called it short-term medical, basically to get around the definition of group, but they provided benefits at the same level as the individual market, and they had no pre-ex underwriting, any of that. So when we looked at the loss experience for that group, just because we could see their rate filings compared to what we were seeing, is there was like this joint benefit to everybody. It was really interesting. So I think that if you look at the income level on the enrollment stuff out of the PUF data from the last 3 years, now that we've started to see those woodwork people come back to the ACA market with the subsidies being retinkered, we could learn a lot about, did only sick people stay? Or,
Right.
you know, so I think that there's probably some data you could find from somewhere, but it would be fascinating to know, like, are they helping the market? They're paying full freight. So if you have healthy people paying full freight instead of the government putting in that money, there's got to be so much money there, right?
Yeah, no, I agree. It's got to be. I think that part of the market's really interesting, and I don't know a ton about it, but I'd like to. I agree.
Thank you for your presentation. It's fabulous.
Thanks. I appreciate your comments.
Great. So Joel Michaels is next, and how are we doing on time? That may be the last one we have time for. Go ahead, Joel, the floor is yours.
Yeah, thank you. And similar questions. It amazes me how adverse selection feeds into all kinds of regulations and policies without being particularly well understood. And in particular, the Affordable Care Act marketplace. I think just this week, the government announced a new rule of making it more difficult for short-term limited duration plans. And as I think the previous speaker mentioned, you know, small employer groups have moved to self-insuring and going to, you know, a favorable risk selection approach. And in both of those cases, the argument is you can't do that, okay, because it will adversely affect the overall Affordable Care Act risk pool. And I just wonder how much sense does that make anymore, given how heavily subsidized that pool is, that you'll get enough risk distribution because the government is bearing a significant part of the cost. And then it does sort of leave out this question, okay, well, if that's the case, how well does the Affordable Care Act market work for those who remain who aren't subsidized? Maybe the answer is it doesn't work that well, and all the more reason why you should let these escape valves, short-term limited duration plans, small employer group plans that are not community rated, let them go ahead and operate and forget your arguments about adverse selection. Any thoughts about that?
Yeah, I mean, I think that generally these marketplaces have proved to be remarkably resilient to selection. And I think, like, you know, we removed the mandate and we removed the penalties, and like things didn't change that much. And I think, you know, a lot of us were saying they're probably not going to change that much. Like, a lot of us thought that was predictable because, like, the bulk of the marketplace is these subsidized folks who have these prices that are, you know, these subsidies are linked to the price. They're completely sheltered from any kind of price increase. And that turns out to be like enough to prevent any kind of death spiral. I think that still for these, like, for the unsubsidized groups, it is the case that like prices have gone up in this market to some extent. Like they're high, and like people don't like that, and they're high and the coverage is not great and people don't like that. And I think on the one hand, like part of that is that, well, healthcare is expensive. And on the other hand, like, I think there have been a bunch of things that have happened in this market that like regulators have allowed to happen because the bulk of the marketplace is sheltered from any price increases, right? And so you see things like where, you know, I have this other paper where we talk about like really aggressive risk adjustment transfers can lead to kind of higher prices. And if it's the case that that people are unsubsidized, that it can drive people out of the market. Okay. That doesn't happen a ton when, you know, you have these people with these price linked subsidies. It's also the case that like those, the silver loading to deal with this removal of the CSRs, like
that wasn't felt at all by the subsidized consumers, but all the unsubsidized consumers saw big price increases because of that, right? And a variety of things like that, that like kind of the regulators have kind of ignored like this other group. And what I don't fully understand is the extent to which that other group has been okay, both because of what you're talking about, like these types of alternative contracts, and because, or alternatively, because they're purchasing off-exchange coverage that is like, it is like, you know, it meets all the ACA requirements, but it's just not, it's not sold on the exchange. It's only sold off the exchange, and so you don't get the subsidized people enrolling, and so they've kind of bifurcated the market in that way. And like that's something I think like I'd like to understand better, and I'd also like, you know, the regulators to understand better is like, what does this other kind of forgotten kind of higher income part of the market look like? And I'd love to see more work on that in the future.
Well, seeing no more raised hands and having no more questions in the queue that I can find, I think it's just time to say thank you again, Tim, for showing up and with such a fabulous, interesting paper. And yeah, I mean, I think you've reached an audience of people who are going to take this work and think about it in their professional occupations. So that's great.
Good. I want you to do
Thanks
that.
again.
Yeah, always happy to talk, and thanks for having me. This was
All right. Come back soon.
all right.
All right.
Everyone.
Okay.
Yeah,
Bye.
see y'all.
Bye, everybody.